Hi, everyone. I'm Lori Radke, and I'm delighted to be part of this exceptional community and to open up tonight's webinar. While I officially joined Crohn's and Colitis Canada a couple weeks ago, I'm no stranger to IBD. Like you, this cause is personal for me. My mom has been living with ulcerative colitis for over 50 years now, so I've seen her go through the ups and downs of this unpredictable disease. And it hasn't just impacted her, it has impacted our entire family. I've also seen the tremendous progress made over time in building awareness and increasing the availability of new treatments and support programs. I am so happy to be part of this engaged community and to build on this progress and momentum. Speaking of momentum, Gutsy Walk is only 10 days away. Gutsy Walk is our annual fundraiser that connects the IBD community from coast to coast to drive awareness, to support each other, and to fund the next set of promising research. There are thousands joining the event and some impressive teams and individual fundraising results. It's inspiring to see all of these people and organizations come together to help the IBD community. I really hope that all of you will be part of this impactful event. It's taking place on Sunday, June 6th. Personally, I'm excited to walk here in Stratford with my daughter, Grace. Thank you to our volunteers, donors, organizations, researchers, and healthcare providers for everything you continue to do. Because of you, we are driving forward important research, and because of you, we can continue delivering programs like these webinars. We're looking ahead with hope. As a key member of the Crohn's and Colitis Canada team, I have the honor of supporting a mission that started in 1974 with a promise that we would find the cures for these devastating diseases and improve lives. And together we've made many advances toward this goal. Crohn's and Colitis Canada believes deeply in our mission to cure Crohn's and colitis and to improve the quality of life of everyone affected. We're working hard to support you with information, resources, and through research. Tonight is our 25th webinar. As always, this information and the webinar recordings can be accessed on our website at crohnsandcolitis.ca. And with that, a huge thanks also to our task force, who continue to meet to discuss policies and recommendations necessary for our community. And a big thank you to our fantastic moderators who will be providing the latest updates tonight. And since the question and answer time has been so popular at our past webinars, we've allocated more time for questions. Our first moderator is Dr. Gil Kaplan. He's a professor of medicine at the University of Calgary. He's an adult gastroenterologist and epidemiologist, and past chair of the Scientific Medical Advisory Council. And joining him is Dr. Eric Benchmal. He's a professor and pediatric gastroenterologist at the Hospital for Sick Children and University of Toronto. He's the NASPGHAN Canadian Counselor and the chair of the Scientific Medical Advisory Council, and he's a Crohn's and Colitis Canada board director. Thank you all and enjoy the webinar.
Thank you, Lori. Thank you for
Thanks, Lori, and welcome to the position. It's great news that we have you on board, and we look forward to working with you in the future.
Yeah, Eric, this is like our 25th webinar. I was like, I actually stopped counting, and I was surprised when Lori said that. I remember the first one on March 19th. I feel like we're on a roller coaster that just keeps going round and around.
Yeah, I'm hoping for a celebratory pin or something. Feels like I've done this for 25 years. That's how long this year has passed.
Absolutely. And in fact, this is one of the rare webinars where we actually don't have any panelists. We actually did a very similar type of webinar, I think roughly a year ago in May or early June of last year, where we just been getting a lot of questions. And we just thought, Eric and I just thought we could just try to answer many of your questions here tonight over the course of the next hour. We know that every time we bring in a panelist, we always ask them to do presentation. We typically ask them to do it in about 10 minutes. It usually take 15 to 20 minutes eating into our question and answer period time afterwards. And so we just thought today we could just kind of focus on that, and Eric and I could try to field some of those questions, recognizing that, we're not, the world experts on all elements of COVID and IBD, but we'll try to give it our best try.
Yeah, and many good questions have already come in. We're going to try to field as many as we can, and then you can put additional questions in the Q&A box. If you click at the bottom of your screen, Q&A, you can type your questions in there, and we'll try to get to them as well.
And so tonight, as I mentioned, Eric and I want to focus on answering questions. So I have a brief one-slide overview of the epidemiology of COVID-19 that you can see right now. And as you can see, as of May 27th, nearly 170 million people have been diagnosed with COVID-19, over 1.3 million in Canada alone. The Secure IBD Registry, which is an international database of individuals with IBD who have tested positive for COVID, in that database, on March 19th, there were 21 patients with IBD. Today, over 6,000 cases have been reported throughout the world. While COVID-19 is impacting regions in Canada differently, as a whole, we can see that Canadians are bending down the curve of the third wave of the pandemic. This graph shows the daily number of cases of COVID diagnosed over the past year in Canada. During the first wave of the pandemic between March and May of 2020, daily cases were exceeding over 1,500 diagnoses a day. At the peak of the second wave in January and the third wave in April, over 8,000 cases a day were reported across Canada. In fact, in the valley of the second wave, we diagnosed around 3,000 new cases a day of COVID across Canada, which was higher than the peak in daily cases during the first wave. What we don't know yet is how far will the third wave crash down. We're all hoping these cases approximate the rates observed in the summer of 2020, so we can get back to a semblance of normalcy. Now, the epidemiology of COVID-19 in Canada entirely depends on a tug of war between variants of SARS-CoV-2 and the vaccinating society. If you remember from last week, I discussed the virus's reproductive number. The reproductive number means the average number of people infected by one sick person in the absence of interventions to control the virus when the whole population is susceptible to infection. We know that variants of SARS-CoV-2 have made the virus highly infectious, meaning it's easier to transmit from one person to the next. In the absence of natural immunity to a virus or availability of vaccines, the only way to drive this reproductive number of a virus down is to institute public health measures, such as hygiene, physical distancing, masks that we're all wearing, personal protective equipment, and then of course, staying home. Now, we're all making these sacrifices today as a bridge to building up herd immunity of society through mass vaccinations. If enough people are vaccinated in society, they form a shield around individuals who are susceptible. For example, those waiting to complete both shots of their vaccine, or those who've not developed strong immunity after their vaccine. In the meantime, the tug of war between variants and the vaccine, as well as the actions of the public to prevent transmission, will define the height of subsequent waves of COVID-19 in Canada and ultimately the weighing of SARS-CoV-2 from the world. Now, Crohn's and Colitis Canada has received many questions from the IBD community, most of whom have received their first vaccine, but are still waiting for their second shot. And Eric, I want you to come by and answer this question for the IBD community, which is, what is the latest information that we have on the effectiveness of the vaccines for those with IBD?
Absolutely, Gil. And I'll give a bit of an update also on how we're doing as Canadians with vaccinating our population. So you should be able to see my screen now. So this is a bit of an update for today, as of today. So I showed this same graph from Ryan Imgren, an epidemiologist in Ontario, last month, and actually our proportion of patients last month who had received, proportion of people in Canada who had received one vaccine was only 30%. This month it's 53%. So we are making headway with administering vaccines to our population, and now more people in Canada have gotten at least one shot than have in the United States, which is fantastic news. Again, compared to last month, when I showed this, oh, sorry, this is the graph from last month. So I should say, so this is from April 28th, where you can see that last month, 34%, 34 people per 100, 34 vaccines per 100 population in Canada were administered. Now we jump forward to this month, and we're actually at 58 vaccines administered per 100 people. So some people have gotten 2 vaccines, obviously, and some people only 1. But you can see that we've pulled ahead of the European Union and other countries. We're still behind the United States, Israel, and other countries that have heavily vaccinated their population, but we are certainly doing better and we are making headway, which is excellent news. When you look at the number of vaccines being administered daily per 100 people, we're now ahead of the United Kingdom, the European Union, the United States, and Israel. Obviously, Israel has more of its population vaccinated, as does the United States, but we've now pulled ahead and we're about administering double the number of vaccines that the United States is right now. So again, all excellent news. It means that the vaccines are coming into Canada and we are getting them out into people's arms. So this is a look at the proportion of people who have been vaccinated as of today. And about 49%, well, over 50% of the population has received one dose of vaccine. Now, where we're falling behind is that only 4.6% of our population have received 2 doses of the vaccine. That compares to about 60% of Israel, 35% of the UK, 40% of the United States, and 16% in the European Union. So we've really prioritized giving as many people as possible 1 dose of the vaccine, to the detriment, to a certain extent, of giving people 2 doses of the vaccine. And I think generally we can say that this strategy has worked. And we are certainly, as Gil showed earlier, we are bending the curve at this point. And I think that's partly due to the vaccines. I think what's even more important is that we're reducing hospitalizations and ICU admissions and deaths, because we have at least partial immunity in the majority of our population, and that reduces the severity of the illness. Now, I think that we're going to see in the next few weeks a concentration towards getting a second doses into people's arms, hopefully including people who are immunosuppressed and people who are at risk for getting COVID despite having one vaccine. And that brings me to, well, I'll first just go over this again. These are the 4 vaccines available in Canada right now as approved by Health Canada. As you know, we have not administered any of the Johnson & Johnson or Janssen 1-dose vaccines yet. There's been a quality control issue, and the ones that we've received have been stuck in freezers being evaluated by Health Canada. The AstraZeneca vaccine, most provinces, I would say, are now not administering it as a first dose because of the risk of the blood clots in first dose, and because we have much more of the Pfizer and Moderna vaccines available. Many provinces will be administering the AstraZeneca vaccine as the second dose in people who got AstraZeneca as the first dose, because the risk of blood clots is in the range right now of between 1 in 600,000 and 1 in a million if you did not have a blood clot after the first dose. So we'll see more people getting second dose AstraZeneca vaccines. If you got your first dose, that you may qualify for that. Right now, Pfizer and Moderna are really the primary sources of vaccination that we're giving in Canada. And I should note that as of very recently, children or older children and adolescents are receiving the Pfizer vaccine. 12 and up is what's approved by Health Canada. And we just learned a couple of days ago that Moderna has will be releasing the results of its clinical trial. Right now, it's only a press release, but their clinical trial shows that the Moderna vaccine also works in children of 12 and up and is safe in children of 12 and up. And so we will be expecting that children will qualify for that. Younger children, the trials are still ongoing. We don't have the results yet. So Health Canada has not approved either of these vaccines for children under the age of 12 yet. So again, if you want to learn more about what our vaccine recommendations are, as far as the Crohn's and Colitis Canada, COVID-19 and IBD task force, you can see them here. There's a QR code that you can scan. You can take a picture of and scan with your phone now. In general, just to remind you, do discuss it with your healthcare provider and your IBD care provider. But in general, we are recommending COVID-19 vaccines for everybody with IBD. You may be eligible for vaccine priority access, not because you have IBD, but because of other things. You should not be deprioritized just because you have IBD. You should not be discriminated against just because you have IBD. You should receive it when you qualify for every other reason. And which vaccine is recommended? Really, the recommendations that we're giving, similar to most public health and infectious disease specialists, are the first vaccine that you have available, you should get it. So if you qualify for a second dose with AstraZeneca, do not wait for the Pfizer or Moderna vaccine. Get your second dose with AstraZeneca. Get fully protected as soon as you can. Similarly, if you qualify for Pfizer or Moderna, get it as soon as you can. it will save lives. Last month, we had Charlie Lees from the UK presenting the results of the Clarity IBD study, which obviously raised awareness in IBD patients that there is concern that after one dose of the vaccine, whether it's AstraZeneca or the mRNA vaccines, Pfizer and Moderna, that people with IBD may not be fully protected after one dose and may not be protected at all after one dose, but they do mount a second dose. They mount an excellent response after 2 doses. And you can see there's a clip on YouTube just dealing with the results of the Clarity IBD study. If you go to that QR code, it'll take you right to the YouTube channel, and you'll see just, I think it's about a 6 or 7 minute clip on the results of Clarity IBD. So, based on Clarity IBD, we, Crohn's and Colitis Canada, have asked and have recommended that IBD patients who are on immunosuppression therapy, so things like azathioprine, methotrexate, anti-TNF therapy, infliximab, adalimumab, and other biologics, that they be prioritized for the second dose and that it should be on label 3 or 4 weeks after the first dose. Unfortunately, that has not happened yet, and most ministries of health, to my knowledge, have not included IBD medications on the list of medications for prioritized second dose. So right now, most people are qualifying for their second dose between 12 and 16 weeks after their first dose. This study actually came out very recently on May 12th in gastroenterology. And I want to review the results because I think they're important in light of that second dose idea, right? And that IBD patients may not be completely immune after a first dose. So this is a study that used Veterans Health Administration data. So it's from a large database to look at people with IBD. Now, remembering that people in the Veterans Health Administration databases, those are veterans and their families who are being treated by VA hospitals in the United States. So it's not the typical population and certainly not the typical IBD population. The median age of this study was 68 years old, so they were older, and 92% of people in this study were male. So not many females because of the gender distribution in the US Armed Forces. They could have been on any IBD medication, and more than half of them were on 5-ASA only. So more than half of them were not immunosuppressed, but about 30% of them were on biologics. And of those 30% who were on biologics, about 6 or 7% were on vedolizumab or Entyvio, so not as immunosuppressed. But the rest were primarily on anti-TNF therapy, infliximab or adalimumab. They looked at comparing whether patients were fully vaccinated and what their rates of infection were after that, and what the rates were if they were partially vaccinated, so they only got 1 dose. And fully vaccinated means they looked at infection rates 7 days after their second vaccine. So what are the results? So you can see, compared to unvaccinated people, there were not a lot of infections in vaccinated people, only about 10 in the Pfizer group and 11 in the Moderna group, those who got Moderna vaccines. It appears that there were lower rates of infection when you just look at the raw percentages, even whether you're partially vaccinated or fully vaccinated. But they did do a fancy multivariable regression analysis and tried to control for as many confounding variables, things that might have influenced the results and made patients who were vaccinated different from those who were not vaccinated. And this is really the bottom line of what they found, is the amount that you were protected was far, far higher if you were fully vaccinated compared to if you were partially vaccinated. So they looked at your likelihood of getting any SARS infection as measured by a test. They looked at severe SARS infection as measured by hospitalization or ICU admission. And they looked at mortality, but there were so few deaths in the vaccinated group. They really looked at all-cause mortality. So they didn't necessarily have to die from COVID, but at any point after you got the vaccine. And you can see that in general, partially vaccinated people were not as protected as fully vaccinated people. They also then split it off into people who died of COVID, and people who were fully vaccinated were far less likely to die of COVID than people who were unvaccinated, but not enough in the other group, the partially vaccinated group, to come to any conclusions. The authors could not identify any medications that were associated with better or worse prognosis or better or worse response to the vaccine. And it's worth noting that there was not a single vaccinated there was not a single case of COVID in fully vaccinated people who were on anti-TNF therapy. So that's good news for people who are on anti-TNF therapy, that it looks like you will mount a good response to 2 vaccines if you get both doses. These are some of the survival curves. So higher means better. This is your likelihood of remaining without COVID infection at all. So if you were fully vaccinated over time, your likelihood of not having a COVID infection was in the range of 99.5%. So excellent response to 2 vaccines. But you can see that partially vaccinated people had the same likelihood of getting a COVID infection as unvaccinated people. There was really not much difference. This is your proportion with severe COVID disease. And you can see that there was not a statistical significantly difference in this analysis, but just based on the colors, you can see that fully vaccinated people did better than unvaccinated or partially vaccinated people. Now, this is an interesting survival curve because it shows that your likelihood of survival, meaning your likelihood of not dying after the COVID vaccine, was far better, and this is all-cause mortality, remember, for any reason, was far better if you were fully vaccinated, but it was not statistically significantly different in this analysis. But you can see the curves that it almost looks like the partially vaccinated people had a higher risk of dying than the unvaccinated people. But that gives you a clue that there's some weaknesses to this study, because obviously that doesn't make sense. And what's happening here clearly, I think, is that you probably had a reason for being partially vaccinated, meaning the patients in this group might have been sicker and therefore less likely to receive their vaccine and their second dose, and therefore much more likely to die having been partially vaccinated. So it's not necessarily that they picked up COVID and died from that. The other issue is that those patients who were sicker may be more likely to be tested for COVID if they got symptomatic, right? Because they may have more severe COVID because they're sicker for other reasons. So you're more likely to pick up positive tests in that group. So it's not as simple as saying that there's no benefit from being partially vaccinated, getting only 1 vaccine, but you should act as if you're not immune if you've only received 1 vaccine. So you have to be very, very careful after 1 vaccine. But again, the good news is there that after 2 vaccines, and I would say don't go with 7 days, go with 14 days after 2 vaccines. But after 2 vaccines, it's looking likely that no matter what medication you're on, you're likely to be well protected. And this advocacy work that we're doing is still on that website. You can read more about our kind of recommendations when it comes to advocacy to try to get you the second vaccine earlier. I do want to mention that the CBC's national broadcast tonight, we believe it was postponed from Saturday. But we've heard that it's airing tonight. Dr. Ellen Kunzig, who's on our COVID-19 task force, is being interviewed about the issue of the second vaccine and about the frustration that IBD patients who are immunosuppressed are not being prioritized for this second vaccine. So do tune in to the airing of the national tonight, and hopefully you'll see some more information about that. And hopefully that's going to raise awareness of all the ministries of health that this is an important issue for IBD patients. So with that, I'm going to stop sharing my screen. There we go.
Yeah, and Eric,
we'll launch into my pleasure. And we'll launch into the Q&A part of the broadcast tonight.
Yeah, it was a brilliant presentation, and it just for the IBD community, for those of you who have watched these webinars month after month, particularly since November, December, when we've been starting to talk about vaccines, you see one of the key themes is every month our task force is trying to keep up to speed. And it's a huge amount of literature, so this is not an easy task, with all of the most up-to-date literature to help inform us, which can help inform CC and its advocacy. And then we're trying to use these webinars to present the latest information. And Eric's a great example, like the VA study literally just was published in gastroenterology within the last week or so. And so, we reviewed it, Eric presented it, and we'll keep doing that kind of month to month. And so really appreciate you summarizing that data, because we're learning more and more about these vaccines, and in particularly how they're impacting patients with IBD. Now, we've had a lot of questions from the community around vaccines. And I think you've actually covered quite a bit in the presentation, but what I'd hope to do, and particularly with this next question, is to kind of maybe ask you specifically about some elements that you've discussed, just so we can highlight it with like clear specificity, because this has actually been one of the most common questions, which is, you know, what is the ideal time between first and second dose of the vaccine versus what's happening in Canada right now, and what are the implications of that?
Yeah, so that's not an easy question, and I might throw it back to you as well, but I'll take a stab at it first. So I think the one thing that I didn't present that I kind of now wish I had, because this question has come up, is there have been data now from the UK that are showing that when you delay the second dose, at least of the AstraZeneca vaccine, going out to 12 weeks, the vaccine may actually work better. And that's really encouraging. It kind of reinforces what Canada is doing for the general population is the right thing to do by delaying things and waiting for the immune system to mature. And that's obviously an oversimplification of things, but it seems like, at least for AstraZeneca, 12 weeks is optimal for the general population. And I think that probably for the mRNA vaccines, Pfizer and Moderna, it's going to be similar, that if you wait a little bit longer, you probably will have good effectiveness, although they're so effective to begin with that I don't think it's as much of an issue.
And just to cut you off, Eric, just to let you know, there has been some data in the general population with the Pfizer vaccine too, showing some advantage with delaying within 12 weeks as well. So sorry to interrupt you, just to—
No, that's good, that's great. That being said, you know, I think that for IBD patients who are immunosuppressed, because we're thinking the first dose is not as protective as with the general population, you're then balancing, you know, potentially catching COVID and getting really sick from COVID versus getting an extra few percentage points of effectiveness by waiting a few weeks of the vaccine. So I think that our recommendation at Crohn's and Colitis Canada is, even if it's not 12 weeks or 10 weeks, you should be getting it as early as you possibly can. And if that means 3 or 4 weeks, get it at 3 or 4 weeks, because you want the protection, right? You don't necessarily need that extra percentage points. You want a little bit of, you want more protection than one dose will offer you. But I think it's a conversation that you can have with your doctor, because if you live in a region with very little COVID out there, and you want to optimize your vaccine, right? If you're not exposed to COVID, if you don't have to go into work every day, if you're okay with working from home and being at home, and you don't have kids going to school, coming in and out with possible infection, then you may want to wait a little bit, right? Then maybe waiting to 12 weeks is okay. But I think it's something you have to kind of decide for yourself as to what's the risk and benefit. I think, you know, myself living in Ottawa, working in Toronto, these are high prevalence areas, and you being in Calgary and Alberta, you know, we're in the middle of bad stuff right now. All things are getting better in Ontario. I think that for IBD patients in my communities in Ottawa and Toronto, I would recommend getting the vaccine as early as you possibly can. And, you know, we're trying to ask for the ministry to give it earlier for immunosuppressed IBD patients.
Yeah, and just for the IBD community to know, I mean, this is the task force recommendation is to go on schedule, which is typically about a month after the first dose. We've advocated that. We've kind of given that recommendation. Crohn's and Colitis Canada, CCC is advocating to different bodies, whether it be NACI, the National Advisory Committee for Immunization, the individual health ministries per province. They're dealing with very complex issues. CCC is not the only group advocating for certain things. So some provinces have been more or less flexible with this thing, but for the most part, most IBD patients are still maintaining that delay. But we're continuing to advocate for that as strongly as possible. And in fact, the other way that we can sometimes advocate is through the media. And this, I want to personally thank Ellen Kunzik, who is being a member of our task force, both as a researcher and a scientist, but also as a patient with Crohn's disease. And she put herself out there to speak to the national, which we heard potentially she's going to air tonight. Maybe after this webinar, we'll go and look for it. And, you know, I can tell you, somebody who's being interviewed by the media, it is, your heart starts racing a little bit when you're being asked in front of a camera. And that's just talking about kind of scientific aspects, but she's actually talking about her personal experience as a patient with IBD, trying to navigate a system to get a second shot. And we're hoping that efforts like this, whether it be direct contact with governments, whether it be through the media, will in some way shorten that interval for you. And if that happens, fantastic. If it doesn't happen, know that you just have to wait it out. I mean, we're fortunate enough to live in a country where vaccines, including the second shots, will be coming. For some people, it may not be as quickly as we want it, but it will be coming. And you just have to maintain the same due diligence that you've had over the past year, just to kind of create that bridge to getting to the next level. The other comment I just wanted to add, and this is specifically about questions that was asked around what is the impact of drugs, whether you're on Remicade or Humira or other types of therapies on the vaccine efficacy. And Eric shared the data about IBD Clarity, which was done in the UK, and the Veteran Affairs database that was done in the United States. And I think there's actually some interesting things to compare those two studies. So first of all, in the US, most people, IBD or not, are getting their first and second shot on schedule. And if you were getting your second shot outside of that month schedule, it's typically, as Eric mentioned in his presentation, either some kind of factor, including some people are just kind of just waiting and being delayed to get their second shot. Like they're making that personal choice to not come in and be scheduled immediately. We as Canadians don't have that choice. Similarly, people in the UK don't have that choice as well. And so many of them were getting their second shots delayed and so on. So in the IBD Clarity study, they looked at people on infliximab, which is an anti-TNF. It's the same as Remicade and its biosimilars like Inflectra, also analogous to drugs like Humira, which you might be on, or Simponi that you might be on. And they compared it to people who are on vedolizumab or Entyvio. And the big difference between these two medications is that anti-TNF therapies systemically blocks the immune system on a whole level. And that's why we can use it to treat rheumatoid arthritis as we can treat it for Crohn's disease and ulcerative colitis. Whereas Entyvio or vedolizumab blocks the immune response to the bowel. So it's very effective for Crohn's disease and ulcerative colitis, but for example, a rheumatologist wouldn't prescribe it for rheumatoid arthritis. And the fact that it is bowel specific, there's an underlying theory that you shouldn't have any impact in developing antibodies to vaccines or antibodies to infections. And that's actually what they did show in IBD Clarity, is that after the first dose of the vaccine, there was a blunted response, and that response was greater on people who were on infliximab or this anti-TNF therapy than those on vedolizumab or that gut selective therapy. Interesting, the other thing they did is they looked at people who were on combination therapy. So they were on a drug like a biologic, plus being on an immunomodulator. And an immunomodulator are drugs like azathioprine or Imuran or methotrexate that we use to help kind of reduce antibodies from being formed against the biologic, and also help with synergy and helping the drugs work better to treat your IBD. And it being on that combination therapy also had an effect of blunting the immune response. But I think the key thing that we saw, both from IBD Clarity, as well as to the VA study, as well as a few other studies that we haven't mentioned, is that regardless of being on any of those drugs, once you got that second shot, the immune response came back and people were very strongly protected against the vaccine. But the other important thing to recognize, and this is whether you have IBD and on immunosuppressed or somebody in the general population, is there are people who still can get COVID after the vaccine. But as Eric described, most of those people, when they get COVID, are mildly symptomatic. Very few end up in hospital or having severe illness, like, for example, ending in ICU or dying from it. So the whole idea is to kind of bring that immune response, bring those antibodies to, if you get exposed, you either don't even realize you get the infection, or if you do, it's a mild infection that just keeps you at home.
Yeah, and the other thing to point out is that so far, the vaccines seem very effective against the variants of concern that you've been hearing about, at least the ones that are in Canada, the variants of concern that have originated in the UK, in South Africa, and in Brazil. Things are looking good that the vaccines work well. I think the jury is still out on the variant from India, but the UK is now experiencing it, and they've seen a bit of a spike in their rates. Their rates are very low, which is excellent, but they've seen an increase. The question will be, even if you're infected with the variant from India, will you get very sick with it? And we're hoping that the vaccines will still prevent you from getting very sick with it. So we'll have to see how things go over the next few weeks.
And Eric, just a question from the audience that it's important for us to address as well. Can we mix vaccines, and what information do we know about that right now? And by mixing, meaning like the mRNA vaccine and the non-viral replicating vector vaccines like the AstraZeneca vaccine.
Yeah, so I just want to again put the caveat out there that neither Gil or I are vaccinologists. We're not experts in this. We may have heard what you've heard on the news and maybe read a little bit of the article, the scientific article, to understand it. So just with a grain of salt, right? But I think the bottom line is we don't know yet. The preliminary results of the UK clinical trial showed two things. They didn't look at whether it's as effective as mixing the vaccine, so going from Pfizer to AstraZeneca or AstraZeneca to Pfizer when you get your two shots. What they looked at is side effects, adverse effects, and it seems as though switching, so going from one to the other, people experienced more side effects after their second shot than if you got the same shot twice. That may be an indication of better immune response, that your body is mounting a stronger immune response to the vaccine, but that is stretching the results a little bit. We just don't know that yet. And so we're still waiting to hear the results of the UK study that show, your immune response and whether it prevents you from getting the virus. And I'm sure Health Canada is looking very carefully and watching very carefully for those results, because they do want to be able to mix if they can. And I don't know, Gil, you haven't heard any more information about that in the past week or so?
No. I think just all we know is a little bit about the safety signal, but the effectiveness piece, which I think will actually have a huge impact on the way that vaccines are delivered, not just in Canada, but around the world. People are still eagerly waiting. But I have a feeling that when that comes out, you'll be seeing it on the CBC, first thing right away.
Right away, yeah, for sure.
And that's probably a good segue into the next question.
Yeah. So, Gil, I'll ask you this question. Are vaccines safe for people with IBD?
Yeah, no, and we touched a little bit about safety just when we were talking about mixing vaccines, but the person who I think describes safety of vaccine the best to me, definitely has taught me, was Lisa Barrett, who's been on our webinar a few times. She's an infectious disease specialist, and she's also on our task force. And it's been a huge honor and privilege to have her on the task force, because not only she's super smart, but she's one of the best communicators that I've ever met in our field. And the way that she always kind of described vaccine safety was kind of about like an immediate risk related to it versus kind of an unexpected or longer term effect. And most people will describe after they get their first shot that their arm is sore, and that they may develop some other types of kind of systemic symptoms, like feeling just generally unwell, having fatigue, having headaches, feeling kind of lousy about it. And often those types of symptoms, when you get the second shot, is actually more profound and more raised. And the way that she always kind of describes this is that this is your body reacting to the vaccine to generate the antibodies. And the way to think about it is, a lot of times when you have a viral infection, and you're actually infected, so not a vaccine, but an actual infection, the symptoms that you get as part of the infection, the fever, the runny nose, it's not actually the virus, but it's your immune response fighting the virus. So often those feelings that people are reporting after the first, and particularly after the second shot of the vaccine, the way I kind of think about it is your body is revving up, making antibodies, and actually feeling a little bit unwell is a good sign that you're actually generating good antibodies and so on like that. So then the second question I always kind of ask when it's related to safety is, there something unique about the vaccines in patients with inflammatory bowel disease? And if you remember, the very first safety studies were the randomized control studies. All of the randomized control studies only had people who were essentially healthy. They didn't have anyone with inflammatory bowel disease. They had anyone with an immune compromising disease, but they tested upwards to like 100,000 people and didn't see any major unexpected or unbeknownst safety signal. Now, these vaccines have been administered to hundreds of millions of people now across the world. And there's tremendous amount of registries. In fact, I believe I was reading, and I think this is a pretty apparent fact, that I don't think there's actually been a singular drug or vaccine or something that has been as administered so broadly as these collection of vaccines. And not only in terms of being administered so broadly, but being under such huge scrutiny of any types of effect. And it's that detailed scrutiny that allowed us to pick up very rare events. For example, Eric's talked a number of times about the viral non-replicating viral vector vaccines, AstraZeneca vaccine and J&J, being associated with a very rare risk of blood clots, which are not seen with the mRNA vaccines. And so there's, these types of things we're constantly doing our due diligence to look for. And the question is, now that we've developed registries with patients with inflammatory bowel disease with vaccines, are we seeing something surprising? And reassuringly, we're not seeing any signals that go beyond what we already would expect for the general population. And one of the best studies to reflect that was a study was done from Cedars-Sinai. And they actually looked at over 1,000 patients with inflammatory bowel disease who got first and second dose vaccine. And in Los Angeles, they all got it in like first dose 4 weeks later. And they compared it to several thousand healthcare workers who had all gotten vaccinated in Cedars-Sinai as well. And they found no differences. And in fact, one of the things that they reported on was actually there were people who were on anti-TNF and other types of drugs that actually had less side effects or symptoms. And I remember being on a Zoom video conference with some of the lead authors and just and this was right around the time we were starting to learn that the antibody response may not be as robust. And what I think we were seeing in those early indicators wasn't that, we're getting, less side effects. It's probably those were individuals who were self-declaring as not having generated a robust enough antibody response after that first vaccine. So, but the key thing is we're developing these registries. We're not seeing extra risks. And the last comment I would make is the other thing that's important for risk is in relationship to inflammatory bowel disease is the risk of vaccine doing something to your IBD. And there's been a tremendous amount of vaccine studies outside of COVID that have looked at this issue as vaccines trigger a flare of IBD. And across the board with these studies that have been done, we've never seen something where a vaccine triggers an IBD flare, but it's something that we were looking for with these COVID vaccines. And to date, none of the studies so far have been able to show any kind of link or any kind of risk associated with triggering a flare of IBD as well. So again, just to kind of summarize, essentially the risks are similar to the general population, and we don't see any special risks related to having IBD or being on a drug to treat IBD.
It's funny, there's a question in the chat box that I want to address because it made me smile because they asked, do we have any tips and advice on how to deal with side effects from the second dose? Because people are reporting more side effects after their second dose than their first. And I smiled because when my daughter got vaccinated, she's 16 and she got vaccinated with her first dose, she said she saw on TikTok that if you do this with your arm for hours on end, you won't have as sore an arm. So kids, don't get your medical advice from TikTok. I'm pretty sure there's not much that you can do after the second dose. Maybe this will help with arm soreness, or maybe it'll just make your arm tired and you'll ignore the rest of the side effects.
I recommend taking the day off and watching playoff hockey. That's a good way to distract you from them.
Exactly. There's not much that you can do, and everybody has a different reaction to the second dose. I showed in the last webinar that people who got the AstraZeneca vaccine actually had more reaction to the first dose than the second, whereas the mRNA vaccines was the opposite. I think you just have to anticipate the next day. You may feel unwell, you may have flu-like symptoms, and be prepared to take the day off if you need to.
And Eric, of course, one of the most exciting things that's happened is the vaccine being lowered down to ages of 12 and up. And there's a lot of questions coming in from the IBD community around the efficacy and safety of vaccines for children, particularly those who are 12 and up, and also questions around, what about kids who are under the age of 12? Could you kind of share with us your thoughts as a pediatrician in terms of vaccinating children?
Yeah, so we are absolutely recommending the vaccines for kids 12 and up when they qualify. I think 16 and up have been given the vaccine for quite some time in the United States and Israel with no bad effects. It's very similar to adults. And similarly for 12 and up, the trials seem to show no increased risk of side effects compared to adults, just the minor side effects that everybody else gets. So I think, again, knowing that our kids are going back to school in September, and obviously some provinces are in school now, but for me as a parent, I want my kids vaccinated as early as possible because I want them to be protected and I want their teachers to be protected when they're back at school in September. So my advice for patients is, in general, yes, get the vaccine as soon as you qualify, make your appointment. The only exception that I'm thinking about with my patients right now are if they're on steroids and they're able to protect themselves and stay home. I am thinking that I'm probably recommending to families that if you're going to come down on your dose of steroids soon, like within the next few weeks, and we can wait for the vaccine, I think it's probably a good idea to try to wait for the vaccine, because I think you probably mount a better response if you're on a lower dose of steroids. So, have a discussion with your gastroenterologist. If your child is on steroids right now, it's sort of a risk benefit discussion, right? Again, if you're in a high prevalence area with COVID and you're on steroids and the child is going to school or can't stay home, or a parent is going to work every day, it might be worthwhile to get the vaccine and just get any protection whatsoever. But if you're low risk, maybe waiting till you're off steroids or on a low dose is probably a better idea.
And we did have questions from the audience about, in the IBD community, about family members being vaccinated. And I think that's another key strategy. Whether you're in a family, particularly like a high exposure situation, with a child who's under the age of 12 and can't be vaccinated, or just as we've been talking about it, maybe you've got the first dose, but you're waiting for the second dose and you're still kind of, anxiously waiting, potentially still susceptible to COVID. The more that the people around you get vaccinated, and of course, family and then friends and then contacts, the more the people get vaccinated, the greater the shield is. And so just if there is a situation where you are slipping away from protection, if you've got a good buffer around you, means you're not getting exposed to the vaccine. And so this is something that we would encourage, something that, you're a family member, this is something that you can do for your child, is to get people vaccinated. And one of the really exciting numbers that Eric had mentioned is that we've kind of crossed that 50% of Canadians being vaccinated, which means if every single person who is vaccinated finds somebody who isn't vaccinated and encourage them to get vaccinated if they're eligible, we can really get up to that close to 100% eligibility much faster. And these are things that you can do because we know that there are going to be people, for example, a child who's 7 years old who has Crohn's disease, not going to have access to the vaccine. Let's make sure everyone around them has the vaccine instead.
Yeah, I want to mention something about what you said in terms of caregivers getting vaccinated, so the parents and family members. I think it's worth mentioning that in some provinces, if you're the caregiver of a high-risk person, you may be eligible for your second vaccine early. And so I would speak to your family doctor. The adult can speak to the family doctor and say, listen, I have a child at home who either doesn't qualify for the vaccine and is immunosuppressed, or I have a child at home who's on steroids and is at risk for serious COVID outcomes. Your family doctor may be able to write you a letter to say you're a caregiver of somebody who's severely ill and at risk for severe COVID, and you may qualify for that second dose. I think that really the person who's at risk for severe COVID, the child who's at risk for severe COVID, would be a child on high dose steroids. I think that really is, or there's another health condition that puts them at risk for severe COVID. Really, a child who's otherwise healthy on infliximab or other biologics, we're seeing from the secure IBD registry, is not really at risk for severe COVID. It's really the steroids thing that makes me most nervous. So, if the child is at home and you have to go to work and your child is on steroids, you may want to talk to your family doctor about getting a letter about that second vaccine. This is a good time actually probably to put a plug in for Vaccine Hunters, for the Vaccine Hunters website. And I'm going to share my screen again, and I'm just going to share my my browser here. So if you're on Twitter, you may have heard of the Vaccine Hunters website, the Vaccine Hunters Twitter account. They are an excellent resource for telling you where vaccines are available, when vaccines are available, who qualifies, things like that. Excellent place to follow. But they specifically put, this is their pinned tweet right on their front page. They have a Discord channel. And if you don't know what Discord is, it's basically a chat group. So you log on to Discord And I'm just going to try to get there. There it is. So this is what Discord is, right? I haven't verified my account or anything, but you go in there and there are actually moderators for the Vaccine Hunters Canada that will help you find a place to get vaccinated depending on your specific circumstances. So for example, again, if you're a caregiver of a very sick child who's on steroids and might have other comorbidities, you want to know, do you qualify to be vaccinated in my region, in my province, and where would I go? Vaccine Hunters has people that will help you do that. So I think it's very much worthwhile. And similarly, I think that it's worthwhile for IBD patients to sign up, regular IBD patients who are immunosuppressed, because at some point, theoretically, provinces or regions will prioritize immunosuppressed patients. And Vaccine Hunters will hopefully tell you when that happens and will reach out to you. So I think it's really a great service that was created by volunteers, physicians and non-physicians, and do a great job at informing the public about where vaccines are available and when. Unfortunately, far better than our governments have been able to inform the public on where vaccines are available and when. So do sign up for that. I think it's a great service. Sorry, I took over the sharing of the screen. So Sarah, you can share the screen and we can go on to the next question. So we dealt with that question. Let's see what's next here.
And then
we dealt with that question too. So Gil, this is an easy question, right? We all know the answer to this question. We don't. So will a third COVID vaccine dose or a booster shot be required for those with IBD?
So, I mean, the short answer, removing IBD from the question, is we don't know if booster shots are going to be needed for the COVID vaccine, and whether it would be something that would be needed for the entire population or would be needed for subpopulations. This is a very important question, and one that once we get to the point where every Canadian has gotten their first and second dose, and now all of a sudden we have extra vaccines. I think it's very important for those extra vaccines to go to other places around the world to make sure that populations everywhere, countries everywhere around the world have access to vaccines. But it will also put us in a position where we can start to think about the impact of booster vaccines. And I know for a fact that there's a number of studies being planned right now to ask this question. And what about the indirect understanding of it? Well, it really comes down to antibodies and what do antibodies mean post-vaccine. And so there's a number of studies now that have been published looking at kind of that early antibody response after vaccine. We've reviewed several of those, like IBD Clarity, but also in the general population. And now people are also looking at antibody response to like once you get the response, does it stay a month later, 2 months later, 6 months later? We don't have enough time yet past the vaccines to know that. But an indirect measure is that people who've gotten COVID, been infected by SARS-CoV-2, and they've developed antibodies, what happens to them? And so there's two types of antibodies to actually be aware of. The first type of antibodies are these antibodies, and call these IgG antibodies, that are in many types of tests that are done. They're not necessarily clinically relevant tests. We don't really test them as clinicians in Canada, but they just measure whether you formed antibodies to the spike protein of the virus, or if you're getting tested for the vaccine of the vaccine. And what we see is that those spike proteins go up quite high, but in many cases, those antibodies start to kind of wane over time and they start to dissipate. We see that in the general population, and we've also observed that in the IBD population. But importantly, there's another type of antibody called memory cells, or another type of immune cells called these memory cells. And these are immune cells that remember the virus or remember the antibody of the vaccine. And if you get exposed to the virus in the future, they get activated and they attack. And there's actually just a paper published recently in Nature that have shown that these memory cells are actually quite active upwards to a year from being infected. I think it was like 8 to 12 months, depending on the population. So that's very promising that for the general population, people will likely have an immune response. The question is it going to be once a year? Is it going to be once every 5 years? And if for those who have been vaccinated with other vaccines, you can see, there are some vaccines we just get once and then you don't ever need another vaccine. There's measles vaccines, for example, where you get once, and now more recently we've done longer term boosters of it. But there's vaccines like influenza, like seasonal flu, that we need to do every year and things like that. So these are the studies that are going to be done. And I think as we explore the IBD population, we're going to specifically have to look at you and people who are on drugs who are immunocompromised to see if a booster shot is going to be required. And these are, again, studies that are happening, that are going to be happening, but we won't see them until everyone gets their second dose.
Yeah, no, that's excellent. I think, yeah, the jury is still out for now. Okay.
And then Eric, so, you've talked about waiting for the second dose. And the truth is, I realize how everyone is frustrated trying to get that second dose, but I think it's something that within the month or months, people are going to get their second shots. And what does that mean? Can they throw off the masks? Like what's the situation? And we see this, for example, the CDC has provided some recommendations. Is there something special that we have to consider for the IBD population? What's going to happen when we're fully vaccinated?
I think the answer is it depends. And I think it depends on a number of factors. So I think it depends, firstly, on what are the rates in the community. So for example, as a healthcare provider, I have received my 2 vaccines, but I am not about to run around to go to Costco with my mask off, and, because the rates are simply too high right now. So although I'm immune, there's a small risk that I could catch it, or I might not know that I'm carrying it and I could bring it home, or I could bring it over to one of my patients and get them sick. So I think for life to get back to normal, the rates would have to be much, much lower. I think the other thing that it depends on is the variants of concern, those genetic variants that we talked about, and what happens, how much are they able to escape the vaccine immunity, or is the vaccine covering them? Do they cause severe infection or give us just a sniffle or a runny nose? So I think what happens with variants of concern will be another question. I think the third question will be how many people around you, in your city, in your town, in your community are immunized and fully immunized. The more people that are fully immunized around you, that's when you get herd immunity. And that means even if you're not completely immune, it doesn't matter because everybody else is forming that shield around you to protect you, and they're not going to pass it on to you. So herd immunity is a key issue, and we're seeing that. We're seeing that in places like Israel and the United States, where firstly, most adults are vaccinated and rates are plummeting as a result. Even people who are unvaccinated are protected. And secondly, I actually don't know what my second point was going to be. So that's the main key point, right? Is that although not everybody, secondly, I think, especially in the case of the United States, is they have about 50% of their population is vaccinated, or 45 is fully vaccinated, but they've had like 10% or 15% of their population had natural COVID infection. So that boosts up the rate of immunity, right? So it's not just 45% are immune, it's probably closer to 55 or 60% are immune because they had such out of control infection rates for so long. In Canada, we didn't have that. We had a very small number of people who had natural infection. And so we're going to need to have more people who are vaccinated in order to get that herd immunity. I think those are the main points, but I think the positive things that we're seeing is in those places where vaccine rates are very high, they are starting to get back to a normal life. They are able to go to movies and to concerts and, congregate in large places and travel. So I think that it's hopeful that I'm hopeful that by the fall, things will start to be getting back to normal, and that we're going to be able to get back to as much of a regular life as we'll ever get back to, knowing that COVID will always be with us, and it'll be like the flu. It may cause an infection, it may cause symptoms, but hopefully it won't kill as many people. And we're just going to have to be very careful to maintain immunity, especially in the older population.
And the only thing I would add is that, we've learned tremendously about the virus, but not only about COVID, but about a lot of viruses. One of the things that was really impressive is if you look at seasonal flu rates across the world during different periods of time, we would have seen spikes of people coming into hospital with flu. Essentially COVID outcompeted with them, and the measures that we did to protect ourselves from COVID, because it was such a highly transmissible virus, so much more than seasonal influenza, meant we actually had very few rates of influenza. And so I think what you're going to be seeing as we go forward in time is that there's going to be some of the things that we've learned to do we may carry forward in the future, whether this is healthcare practice, whether this is public policy, things like that, to help us kind of fight infections in general. But again, like Eric, you said, we're going to have to wait a little bit of time to see how things plays out. The key thing is vaccine protects yourself, and the more people in society that's protected, the lower the rates are. Once those rates are very low, then all of a sudden when you go out, the probability of you coming into contact with somebody with COVID is very, very low, which means you can have more routine contact.
So I think we should both address this question that I see in the Q&A because I think it's really important. And the question is, should we be worried about long-term effects and what it can do to our body since we don't have this data? Maybe Gil, I'll get you to address it, and then I want to speak as well, I think, on this.
For sure. And I'll try to be concise because I do realize we're over time. But so, I mean, the challenge of this disease, the first COVID, and then of course the vaccines that have followed, is this is a brand new disease. This is not something that we knew about in 2019. So our knowledge, while exponentially increasing day after day after day, we only are knowledgeable relative to the time that has passed. So it's very difficult to answer a question like what is going to be the long-term effects of COVID-19 versus the long-term effects of a vaccine. And right now, we're not seeing any major signals for major long-term effects of the vaccine. But again, the vaccine's only been around for a few months. But there are signals that we're learning about long-term effects of the virus. And so even going beyond kind of comparing, the vaccine reducing your risks of, getting super sick, people who've gotten sick with COVID, there's a significant proportion right now that are going to these what are called long haul COVID clinics, where they're being seen by specialists managing COVID after effects and complications. And so anytime we do a risk benefit analysis, where we're trying to say, what is the risk of something that we don't know? Like I can't tell you what's the 1 year risk of the vaccine because no one has had it for a year. But we can start to tell you what the 1 year risk of having a severe COVID infection is if you survive it. And that's not trivial. And so everything that you do, you have to pivot the risks of not being vaccinated and getting COVID and potentially becoming very sick with COVID and then surviving it, but then potentially dealing with long haul COVID symptoms that we don't know how long they're going to last in people. And so that's how I kind of balance the risks and benefits around a question like that.
Yeah, no, I agree. It's not just a risks of vaccine issue. It's a you're balancing risks of getting the virus, dying, or having long COVID syndrome compared to the risk of the vaccine. I think it's also worth mentioning that these appear to be new vaccines. The difference in these vaccines is the way that we are bringing the thing that triggers your immune system to your cells. So the mRNA component, right? We're delivering mRNA into the cell. The cell then produces the spike protein, which mounts the immune response. Or we're using an adenovirus vector to bring it into the cell, same process. Those types of vectors have been used in other conditions, whether it's cancer or other vaccines. The mRNA vaccines have been trialed for many years. This is not a new technology. Have been trialed for many years in animals, and there doesn't seem to be a major problem with it. And in the end, they cause the same type of immune response as if you were to get COVID, because the COVID is presenting that spike protein and your immune system is responding to it, and your immune system is mounting an immune response, developing antibodies so you don't get infected again. So, there's no reason to think that it's going to act any differently from getting natural COVID and becoming immune to it that way, although it seems to be a stronger immune response, which is good for us. And then the other thing is that we have lots of vaccines that also deliver immune responses, right? That cause your body to give immune responses. And so far, not a single vaccine has caused any long-term side effects. So the side effects are short at the time the immune response happens, but none of them have caused side effects 10 years out. None of them have affected fertility. None of them cause autism. none of those long-term issues have been shown to be an issue. So, like the science of vaccines is pretty clear that the way that we build immunity through giving a vaccine doesn't cause a problem in the long term. And for me and my family, I am assuming, and my patients, I am assuming that this vaccine will function very similarly to other vaccines. And yet I'm also balancing a very deadly disease with long-term disability issues. And so for me, it's a no-brainer that we need to vaccinate, and I'm recommending vaccination to all my patients.
And if I could just add, and I appreciate what I'm about to say is speculative, not evidence-based, but I believe we're actually on the dawn of a new kind of revolution in healthcare with mRNA technology, looking at revolutionizing the way we give vaccines to many different diseases, including potentially treating diseases that are not infectious in orientation. And so, and I think there's never been this amount of effort, money, collective, I think in the history of humanity. And I think the effect, once we get past this pandemic and we can start kind of focusing on other things that are not COVID related, the what's going to come out of it, the byproducts, the medical technology through these platforms. This is not the last time you're going to hear mRNA based therapies in the future.
Or viral vector therapies, right? I think that's, we're at the beginning. It's certainly not the dawn because we've been using them for a while, but rather at the beginning of this type of viral technology to treat cancer and other things. So I think this is going to become an increasingly common way of treating patients. So lots of questions, I guess, about Stelara, ustekinumab, Gil, and I'm going off script here. Since it suppresses your immune system and it's not gut specific, do you want to speak about ustekinumab? Are we treating it the same as other immunosuppression?
Yeah, so the most data that we have is on anti-TNF therapy because it's the most commonly prescribed therapy to treat Crohn's disease and ulcerative colitis, particularly if you look at people who have been on it for many, many years and are doing very well on maintenance therapy, including the IBD Clarity study specifically looked at infliximab and vedolizumab because they were infusions. And logistically, to conduct the study where they had to draw blood samples from people, it was easy to do at an infusion clinic because people were there, they're getting an IV for their infusion, and the nurse was able to draw a blood sample that was sent off for serology. And that's why those have been probably the two best studied therapies. Some of the more recent studies that have come out that are outside of IBD Clarity, albeit at a smaller sample size, have looked at other drugs, including Stelara, including tofacitinib, including being on a mesalamine agent like Asacol or Salifalk or Mezavant. The numbers are lower, but because overall the sample sizes of those studies are lower, and because the number of people with IBD on Stelara is less than those on Humira and Remicade and drugs like that. But if you look at that data that's coming out, there is no clear signal that it's different from what we're seeing with the anti-TNF therapy. So I think the key thing is if you're on an agent that suppresses your immune system systemically, probably at least as of May 27, 2021, and the next time we come, we may have different information, but as of today, it looks like the impact is the same. So I would probably treat what we know about like infliximab is the same as what we would know about Stelara, recognizing the uncertainty of the data.
Yeah, no, I agree. So I'm just scanning and seeing whether there are other questions that we didn't directly answer or indirectly answer. I don't see anything specifically. JAK inhibitors, I think it's similar to Stelara. There's really very little information on JAK inhibitors, tofacitinib, Xeljanz. So we can't really directly answer that question until we get more data. Sarah, any other questions that you feel have come up before we wrap up?
I mean, the only other question, we briefly saw it on the slide, that it was one of our questions that was in relationship to audience question, which was, is once everyone is vaccinated, is COVID gone? And the only reason I want to answer this question is really just to make kind of a plug for a couple of things. So first of all, if we can get to everyone being vaccinated, life is going to be a lot better. And we can see that already in other places of the world. But what I really want to highlight is the fact that we are so fortunate to live in a country like Canada that has had access to vaccine. Slower than we wanted it to, but much faster than so many other countries in the world. And I think all of us are looking in the news and seeing what's happening in regions like India, other places across the world who haven't had the same penetration of vaccine or even have access to vaccine yet for their healthcare workers. And I think the key is that once we get everybody their second dose, and the world is generating more and more vaccine, it becomes so important to vaccinate the rest of the planet. And it's not just about the moral, the human, the ethical aspect of it. It's about getting rid of COVID. As long as this is raging in other parts of the world, we're giving the opportunity for variants to develop. As you can see, one bad variant could then potentially circulate, and now all of a sudden we might be needing another booster vaccine to address that variant. And so this is the key, is that while we're closer in Canada, we still have time this is still going to take a bit of time to address COVID globally.
Absolutely. And even then, it's not clear that it's going to go away as such. I think we may be stuck with this virus for a while, but hoping again that it doesn't cause death or hospitalizations or disability, that it really causes a runny nose or a bit of a fever, right? That's really would be an optimal outcome as well. It doesn't necessarily have to be completely gone, but not kill people would be really important. All right, so with that, I think we're going to wrap up. Please do let us know any topics you want us to cover in the future, and provide your feedback in the survey that'll arrive after this webinar. Give us feedback also on the timing. We went a little bit earlier again this month. Last month we started at 6 p.m. Eastern. This month we did the same, but if you feel 7 p.m. Eastern works better, please let us know. Different day, different time, whatever you choose. And we want to thank again all the frontline workers who are working hard at maintaining our food line, maintaining our healthcare system, who are teachers and so on. And thank you for what you do. Now, a big plug. We're almost done. 10 days left until the virtual Gutsy Walk. There is not enough time left, but I think we're very grateful that our team, the COVID-19 and IBD team, has been able to reach our goal of raising $5,000. But I think I'm going to arbitrarily raise our goal to $7,500. What do you think, Gil? In the next 10 days, if we can raise an additional $1,500, what is that? $1,500, $1,600, $1,700 in the next 10 days from the audience, who I know you all are very appreciative of the webinars. We get your messages, we get your tweets, we get the feedback. Thank you for your feedback. But if you've appreciated these webinars and you haven't donated to the Gutsy Walk yet, or even if you have, please consider donating to our team. I'm not going to say donate to me or Gil or one or the other, because we're not in competition. It's really a team thing. So please do donate to our team. Crohn's and Colitis Canada has struggled, as all charities have, with not being able to have in-person events, including the Gutsy Walk not being able to be in person. And I think that it's really important that we support Crohn's and Colitis Canada in all of the educational and research endeavors that they've been doing, as well as the advocacy work they're doing on your behalf. And so if you've appreciated these webinars and all the education that you've gotten over the past year, please do donate to the Gutsy Walk, and you can scan the QR code there. That's Gil and I there. The picture is Gil and I at a Blue Jays game. It feels like many years ago. It feels like decades ago, but it wasn't that long ago. It was obviously before the COVID era. So again, 10 days left to donate. We're going to raise our goal to 7,500 as a team, and we hope that you all can contribute. Thank you. And please follow at Get Gutsy Canada on Twitter, and the YouTube channel that has all of these webinars archived, and you can find all of this at crohnsandcolitis.ca/COVID-19. Thank you very much, everybody. I appreciate your attendance. We both do, and we look forward to speaking to you next month. Take care, everybody. Stay safe.